A very good afternoon. I am Dr. Prakesh and I am working as Assistant Professor in Department of Neurosurgery at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Today I am going to talk about management guidelines in neurotrauma. Introduction. Neurotrauma, the literal meaning of neurotrauma is trauma to the nervous system, that is brain and the spinal cord. But practically, there is no event like isolated neurotrauma. Trauma is a systemic ailment, and several studies have shown that there exists a reciprocal conversation, that is brain crosstalk between brain and various organ systems of the body. Trauma should be considered as an epidemic of the 21st century. Impact of trauma on society. According to latest information from the World Health Organization and the Center for Disease Control, CDC, more than 9 people die every minute from injuries or violence, and 5.8 million people of all ages and economic groups die every year from unintentional injuries and violence. Road traffic accidents alone cause more than 1 million deaths annually and an estimated 20 million to 50 million significant injuries. They are the leading cause of death due to injury worldwide. Improvements in injury control efforts are having an impact in most developed countries where trauma remains the leading cause of death. More than 90% of motor vehicle crashes occur in the developing world. Injury-related deaths are expected to rise dramatically by 2020, and deaths due to motor vehicle crashes are projected to increase by 80% from current rates in low and middle income countries. Trimodal death distribution. First described in 1982, the trimodal distribution of death implies that death due to injury occurs in one of the 3 periods or peaks. The first peak occurs within seconds to minutes of injury. During this early period, deaths generally result from apnea due to severe brain or high spinal cord injury or rupture of the heart, aorta, or other large blood vessels. Saving life in this peak is nearly impossible. The second peak occurs within minutes to several hours following injury. Deaths in this period are usually due to subdural and epidural hematomas, hemopneumothorax, ruptured spleen, lacerations of the liver, pelvic fractures, and multiple other injuries associated with significant blood loss. The golden hour of care after injury is characterized by the need for rapid assessment and resuscitation, which are the fundamental principles of advanced trauma life support, that is ATLS. The third peak, which occurs several days to weeks after the initial injury, is more often due to sepsis and multiple organ system dysfunctions. Care provided during each of the preceding periods affects outcome during this stage. Historical background. In 1976, advanced trauma life support was developed following a plane crash of an orthopedic surgeon in which several children were critically injured. They received injury care, but the resources and expertise they needed were not available. This was unfortunately typical of the way injury care was provided in most areas of the United States of America, even in the 8th decade of 20th century. A new approach to providing care for individuals who suffer major life-threatening injury premiered in 1978, the year of the first ATLS course. Primary brain injury refers to the damage suffered as a direct result of the initial traumatic event and may be caused by penetrating, blunt, or blast trauma. The primary goal of treatment for patients with suspected traumatic brain injury is to prevent secondary brain injury. Now going back to the basic neuroanatomy, it is a schematic diagram showing production, circulation, and absorption of cerebrospinal fluid circulating around the surface of brain and the spinal cord. The blue color shows the neural venous sinuses overlying the surface of the brain. Now, after removing the bony covering of the skull, the meningeal coverings of the brain comes into picture. Outermost is the dura mater. It contains of 2 layers, periosteal layer and the inner meningeal layer. Underneath the meningeal layer lies the arachnoid matter, and the third innermost layer, which lies on the surface of the brain, is pia mater. Between the arachnoid and pia mater lies the subarachnoid space in which blood vessels and cerebrospinal fluid circulates. Monro-Kelly doctrine. The Monro-Kelly doctrine is a simple yet vital concept that explains intracranial pressure dynamics. The doctrine states that the total volume of the intracranial contents must remain constant because the cranium is a rigid container incapable of expanding. When the normal intracranial volume is exceeded, intracranial pressure rises. Venous blood and cerebrospinal fluid can be compressed out of the container, providing a degree of pressure buffering. Now, this is a volume pressure curve, which explains the dynamics of cerebral blood flow in case of neurotrauma patient. Pathophysiology. The volume pressure curve explains the phenomenon which regulates cerebral blood flow. According to this curve, the intracranial contents initially can compensate for a new intracranial mass in the form of extradural hematoma, subdural hematoma, or any tumor mass. Once the volume of this mass reaches a critical threshold, that is the point of decompensation, a rapid increase in intracranial pressure occurs, which can lead to reduction or cessation of the cerebral blood flow. At autopsy, 80% of patients who die after traumatic brain injury have evidence of cerebral ischemia. Cerebral ischemia is defined as cerebral blood flow that is inadequate to meet the metabolic demands of the brain. While the brain constitutes only 2 to 3% of the body's weight, it consumes 25% of its oxygen and receives about 20% of its cardiac output. The brain is almost completely reliant on adequate blood flow. Nearly 95% of the brain's metabolism is oxidative without a significant oxygen storage capacity and limited glucose and glycogen reserves. Delivery of oxygen to the brain is contingent on the oxygen content of the blood and cerebral blood flow. Likewise, delivery of glucose and other substrates of metabolism are based on cerebral blood flow. A discrete metabolic autoregulatory mechanism exists to couple cerebral blood flow with the cerebral metabolic rate of oxygen, CMRO2, so that adequate perfusion exists to support local metabolic needs. Clinical examination of traumatic brain injury patients. Triage involves the sorting of patients based on the resources required for treatment and the resources that are actually available. Clinical examination involves primary survey and secondary survey. Primary survey meant for rapid assessment and immediate resuscitation. Secondary survey involves detailed history in the form of ample history and examination. The primary survey encompasses the ABCDEs, which are the backbone of the ATLS guidelines of trauma care and identifies life-threatening conditions by adhering to this sequence. A stands for airway maintenance with the restriction of cervical spine motion. B for breathing and ventilation. C, circulation with hemorrhage control. D, disability and assessment of neurological status. E, exposure and environmental control. Secondary survey involves detailed history and evaluation. Detailed history in the form of ample. A stands for allergies. M for medications currently used. P for past illness and pregnancy. Last meal, events and environment related to the injury. Imaging modality. CT scan has been the biggest boon to the medical science, not only in the management of neurotrauma. Before advent of CT scan in 1970, the neurotrauma patients were evaluated with the help of X-ray skull only. In those days, most of the interventions were based on X-ray imaging and bare clinical examination to look for the localizing signs. Investigation of choice for brain as well as spine trauma, CT is the gold standard. Glasgow Coma Scale, that is GCS, most important clinical tool for evaluating level of consciousness of the neurotrauma patient, devised in 1974 by Professor Janet and Graham Tisdale. The three basic steps for the evaluation of GCS are observe, assess, and record. Glasgow Coma Scale. The components are eye opening, E, verbal response, V, best motor response, that is M. This is a revised scale in which non-testable component has been added other than previously existing scores. For eye opening, spontaneous score of 4 has been allotted, to sound 3, to pressure 2, none 1, non-testable NT. And for verbal response, oriented 5, confused 4, words 3, sounds 2, none 1. And for best motor response, obeying command 6, localizing 5, normal flexion 4, abnormal flexion 3, extension 2, none 1, non-testable NT. GCSP, the second revision of GCS in 2018, Professor Graham Tisdale published a new paper calling for the adoption of the GCSP score. The first revision was done in 2014 when Professor Tisdale added the component non-testable in GCS. The GCSP is scored from 1 to 15 and is calculated by subtracting a pupil reactivity score PRS from the calculated GCS score. On the other hand, GCS score in its own ranges from 3 to 15. This is the pupil reactivity score in which pupil unreactivity to light is rated with the scoring from 2 to 0. Both pupils unreacting to one pupil unreacting score of 1 is given and neither pupil unreacting is 0. So GCS score has evolved over the last 44 years and now includes new terminology and an expanded GCSP score. They incorporated age and CT findings with GCSP and created GCS PACT, in which they include GCS, pupil, age, and CT findings. Classification of traumatic brain injury on the basis of GCS. On the basis of severity, mild, GCS score of 13 to 15, moderate, GCS score 9 to 12, severe, GCS score of 3 to 8. Brain trauma foundation guidelines for traumatic brain injury patients. Severe prophylaxis. Seizure prophylaxis phenytoin is recommended to decrease the incidence of early post-traumatic seizure, that is within 7 days of injury. Prophylactic use of phenytoin or valproate is not recommended for preventing late post-traumatic seizure. It is level 2 evidence. For deep vein thrombosis prophylaxis, low molecular weight heparin or low dose unfractionated heparin may be used in combination with mechanical prophylaxis. However, there is an increased risk for expansion of intracranial hemorrhage, level 3 evidence. For infection prophylaxis, early tracheostomy is recommended to reduce mechanical ventilation days, but no effect on the overall mortality, level 2A evidence. Nutrition, feeding patients to attain basal caloric replacement at least by the 5th day and at most by the 7th day post-injury is recommended to decrease mortality. It is level 2 evidence. Regarding steroids, the use of steroids is not recommended for improving outcome or reducing intracranial patients. Level 1 evidence. Anesthetics, analgesics, and sedatives. Administration of barbiturates to induce burst suppression measured by EEG as prophylaxis against the development of intracranial hypertension is not recommended. Level 2B evidence. Ventilator therapies. Prolonged prophylactic hyperventilation with PaCO2 of 25 mm mercury is not recommended. Level 2B evidence. Cerebrospinal fluid drainage and EVD system zeroed at the midbrain with continuous drainage of CSF may be considered to lower intracranial pressure burden more effectively than intermittent use. Use of CSF drainage to lower intracranial pressure in patients with an initial GCS less than 6 during the first 12 hours after injury may be considered. This has got level 3 evidence. Now, regarding hyperosmolar therapy, mannitol is effective for control of raised intracranial pressure at the rate of 0.25 gram to 1 gram per kg body weight. Arterial hypotension, that is systolic blood pressure less than 90 mm mercury, should be avoided. Restrict mannitol use prior to intra-pressure pressure monitoring to patients with signs of transinsural herniation or progressive neurological deterioration, not attributed to extracranial causes. This has got level 2 evidence. Regarding prophylactic hypothermia, early, that is within 2.5 hours, short-term 48 hours post-injury, prophylactic hypothermia is not recommended to improve outcome in patients with diffuse axonal injury. It has got level 2B evidence. Now, decompressive cranectomy in the form of surgical intervention. Bifrontal decompressive cranectomy is not recommended to improve outcomes as measured by the extended Glasgow outcome scale at 6 months. A large frontotemporoparietal decompressive cranectomy not less than 12 into 15 centimeters is recommended over a small frontotemporoparietal decompressive cranectomy for reduced mortality and improved neurological outcome in patients with severe traumatic brain injury. It has got level 2A evidence. Classification of traumatic brain injury on the basis of morphology. Skull fractures, intracranial lesions. Skull fracture may be wall fracture or basilar fracture. And the wall fracture may be linear versus stellate fracture or depressed or non-depressed fracture. The basilar fracture with or without CSF leak and with or without 7th nerve palsy. Intracranial lesion, in focal lesions there will be extra epidural hematoma, subdural hematoma or intracerebral hematoma. In diffuse intracranial lesions, it can be contusion, concussion, hypoxic or ischemic injury, or diffuse axonal injury. Algorithm for management of mild brain injury. Definition: patient is awake and may be oriented. GCS ranges from 13 to 15. After taking history and details of the patient, mechanism and time of injury is obtained. Loss of consciousness following trauma, subsequent level of alertness, amnesia, retrograde, anterograde, headache, mild, moderate, severe, presence of vomiting are noted. General examination with limited neurological examination. Now, relevant X-ray, including cervical spine, are ordered. CT scan of head is indicated if moderate to high risk of intervention is required. Admit or transfer to appropriate center if abnormal CT scan finding is there. All penetrating head injuries, prolonged duration of unconsciousness, moderate to severe headache, skull fractures, and CSF leak, persistent focal neurological deficit unnoticed. Discharge the patient from hospital if patient not meeting any admission criteria. Discuss need to return if any problem develops and issue a warning sheet. Schedule a follow-up visit. Algorithm for management of moderate brain injury. Definition: GCS score ranging from 9 to 12. Initial examination, same as for mild brain injury, plus baseline blood work, CT scan of head in all the cases. Admit or transfer to facility capable of definitive neurosurgical care. After admission, frequent neurological examination need to be done. Follow-up CT scan if condition deteriorates or preferably before discharging the patients. If patient improves, that is in case of 90% of chance, discharge when appropriate and follow up in the clinic. If patient deteriorates, nearly 10%. If patient stops following simple commands, repeat the CT scan and manage as per severe brain injury protocol. Algorithm for management of severe brain injury. Patient is unable to follow even simple command with GCS score of 3 to 8. It defines the severe brain injury. Assessment and management includes ABCDE, primary survey and resuscitation, secondary survey and ample history, admit or transfer to a facility which are capable of definitive neurosurgical care. Therapeutic agents usually administered after consultation with a neurosurgeon. That is, administration of mannitol, avoid hyperventilation in the first 24 hours unless sign of herniation present, as very well defined by Brain Trauma Foundation. Hypertonic saline, neurological evaluation, Glasgow Coma Scale assessment, pupillary light response, focal neurological examination, and then repeat the CT scan. Nice guidelines for the CT scan of the head. High risk for neurosurgical intervention. GCS score less than 15 at 2 hours after trauma, suspected open or depressed skull fracture, any sign of basilar skull fracture, for example, hemotympanum, raccoon eyes, CSF autoria or rhinorrhea, battle sign, vomiting more than 2 episodes, age more than 65 years, any patient who is on anticoagulant use, moderate risk for brain injury on CT scan, loss of consciousness more than 5 minutes, amnesia before impact more than 30 minutes, dangerous mechanism of injury such as pedestrian struck by motor vehicle, occupant ejected from motor vehicle, fall from height more than 3 feet or 5 stairs. Warning signs at discharge needs to be handed over to the patients. New symptoms and unexpected complications can develop hours or even days after the injury. The first 24 hours are most critical and you must remain with a reliable companion at least during this period. If any of the following signs develop, call your doctor or come back to the hospital. Inappropriate drowsiness or increasing difficulty in awakening patient. Second, nausea or vomiting are there. Third, convulsions or fits are noticed. Fourth, bleeding or watery discharge from the ear or nose. Fifth, severe or increasing degree of headache as compared to the previous headache. Sixth, weakness or loss of feeling in the arm or leg. Seventh, confusion or strange behavior. Eighth, pupillary asymmetry, peculiar movement of eye, double vision or other visual disturbances. And ninth, a very slow or very rapid pulse or an unusual breathing pattern noticed. Now, a few of the examples of trauma such as subdural hematoma. Incidence, most common hematoma following traumatic brain injury. It appears as a convexo-concave on CT scan. Management regarding subdural hematoma is if thickness of subdural hematoma more than 1 centimeter causing midline shift of more than 5 millimeters with deteriorating GCS, operative intervention is indicated. It generally carries a poor prognosis. This is the CT scan of a 40-year-old male presented to our emergency department with GCS score of E2, V3, M5. CT scan is showing left frontotemporoparietal hyperdense lesion, that is acute subdural hematoma in the form of convexo-concave appearance. Is the post-operative CT showing adequate evacuation of the hematoma with removal of the bone flare because of severe brain bulge. The post-op CT, at the time of post-op CT, the GCS score was E4, V4, M5. Now, extradural hematoma, less common in occurrence as compared to subdural hematoma, characteristic biconvex or lanceolate appearance. If volume is more than 30 ml with mass effect, surgical intervention is needed. But in case of posterior fossa, the volume of 10 ml is the cutoff. Any hematoma more than 10 ml needs to be evacuated. It has got best prognosis if intervened on time. This is the pre-op CT of a patient showing left frontal biconvex lanceolate appearance with hypodensity suggestive of swelling sign or active bleeding, or he may be having anemia also. At the time of CT scan, GCS was E2, V2, M5. Patient was immediately taken up for decompression. Hematoma was evacuated. At the time of post-op CT scan, his GCS was E4, V5, M6. Contusion, most common CT finding following traumatic brain injury. Most of them are managed non-operatively. If significant enough to cause mass effect, operative evacuation is the treatment of choice. It generally carries a good prognosis. Pre-op CT showing right frontotemporal contusion with multiple aspects of pneumocephalus. At the time of presentation, GCS was E3, V4, M5. He was taken up for evacuation of the contusion. At the time of post-op CT, GCS was E4, V5, and M5. Diffuse axonal injury. It generally occurs following a sudden deceleration and shear injury on brain. Is a diagnosis of exclusion, generally unnoticed on CT of the brain. Management, mostly they are managed with medical treatment, generally carries a guarded outcome. The CT scan looks nearly normal. The GCS score is E2, V3, M5. If any patient GCS score is not correlating with the CT findings, this is a diagnosis of exclusion in the form of diffuse axonal injury. MRI is a definitive investigation of choice. But in trauma patient, MRI is generally avoided because it is time taking. It requires patient to be stable, but most of the time trauma patients are agitated, restless, and of course it is more costly. Now, management of spinal injuries. Introduction. Spine injury with or without neurological deficit must always be considered in patients with multiple injuries. Approximately 5% of patients with brain injury have an associated spinal injury, whereas 25% of patients with spinal injury have at least a mild brain injury. Approximately 55% of spine injuries occur in the cervical region, 15% in the thoracic, 15% thoracolumbar junction, and 15% in the lumbosacral area. Up to 10% of patients with a cervical spine fracture have a second non-contiguous vertebral column fracture. Initial assessment of spine injury patients. In a patient with potential spine injuries, excessive manipulation and inadequate restriction of spinal motion can cause additional neurological damage and worsen the patient's outcome. At least 5% of patients with spine injury experience the onset of neurological symptoms or a worsening of pre-existing symptoms after reaching the emergency department. These complications are typically due to ischemia or progression of spinal cord edema, but they can also result from excessive movement of the spine. If the patient's spine is protected, evaluation of the spine and exclusion of spinal injury can be safely deferred, especially in the presence of systemic instability such as hypotension and respiratory inadequacy. Although the dangers of excessive spinal motion have been well documented, prolonged positioning of patients on a hard backboard and with a hard cervical collar can also be hazardous, and they may create potential pressure source. Long backboards should be used only during patient transportation, and every effort should be made to remove patient from spine boards as quickly as possible. Now, neuroanatomy. The spinal column consists of 7 cervical, 12 thoracic, and 5 lumbar vertebrae, as well as the sacrum and the pockets. The typical vertebra consists of an anteriorly placed vertebral body, which forms part of the main weight-bearing column. This is a picture showing the vertebral column, anterior view, and the lateral view. The vertebral bodies are separated by intervertebral discs that are held together anteriorly and posteriorly by the anterior and posterior longitudinal ligament respectively. Posterolaterally, 2 pedicles form the pillar on which the roof of the vertebral canal, that is lamina, rests. The facet joints, interspinous ligament, paraspinal muscles all contribute to the spine stability. Spinal cord anatomy. The spinal cord originates at the caudal end of the medulla oblongata at the foramen magnum. In adults, it usually ends near the L1 bony level as the conus medullaris. Below this level is the cauda equina, which is somewhat more resilient to injury. Of the many tracts in the spinal cord, only 3 can be readily assessed clinically: the lateral corticospinal tract, spinothalamic tract, and dorsal columns. Each is paired tract that can be injured on one or both sides of the cord. Clinical assessment of the spinal cord tracts. Corticospinal tract, located in the anterior and lateral segment of the cord. It controls motor power on the same side of the body, can be tested by voluntary muscle contraction or involuntary response to painful stimuli. Spinothalamic tract, located in the anterolateral aspect of the cord, transmits pain and temperature sensation from the opposite side of the body, can be tested by pinprick. Dorsal column, located in the posteromedial aspect of the cord. It carries position sensation, that is proprioception, vibration sense, and some light touch sensation from the same side of the body. It can be tested by position sense in the toes and fingers or vibration sense using a tuning fork. There is a cross section of the spinal cord showing anterior horn, posterior horn, anterior column, lateral column, and dorsal column, anterior spinal artery, which is single, and 2 posterior spine arteries, the 2 anterior and 2 posterior projections showing the ventral and dorsal rami. Cervical spine injury. When a patient has no demonstrable sensory or motor function below a certain level, he or she is said to have a complete spinal cord injury. An incomplete spinal cord injury is one in which some degree of motor or sensory function remains. In this case, the prognosis for recovery is significantly better than that of the complete spinal cord injury. Dermatome. A dermatome is the area of skin innervated by the sensory axon within a particular segmental nerve root. The sensory level is the lowest dermatome with a normal sensory function and can often differ on the 2 sides of the body. For practical purposes, the upper cervical dermatomes C1 to C4 are somewhat variable in their cutaneous distribution and are not commonly used for localization. Key dermatomes C5 responds to area over the deltoid, C6 thumb, C7 middle finger, C8 little finger, T4 nipple, T8 xiphisternum, T10 umbilicus, T12 symphysis pubis, L4 middle aspect of the calf, L5 web space between first and second toes, S1 lateral border of the foot, S3 ischial tuberosity area, S4 and S5 perianal region. Myotomes. Each segmental nerve root innervates more than one muscle, and most muscles are innervated by more than one root, usually 2. For purpose of simplicity, certain muscles or muscle groups are identified as representing a single spinal nerve segment. Key myotomes: C5 elbow flexors, that is biceps; C6 wrist extensors; C7 elbow extensors, that is triceps; C8 finger flexors; T1 finger abductors; L2 hip flexors; L3 knee extensors; L4 ankle dorsiflexors; L5 long toe extensors; S1 ankle plantar flexors. Severity of neurological deficits: spinal cord injury can be categorized as complete, incomplete or complete paraplegia; thoracic injury; incomplete or complete quadriplegia, that is tetraplegia; cervical injury. Any motor or sensory function below the injury level constitutes an incomplete injury and should be documented appropriately. Signs of an incomplete injury include any sensation, including position sense or voluntary movement in the lower extremities, sacral sparing, voluntary anal sphincter contraction, and voluntary toe flexion. Sacral reflexes such as the bulbocorneus reflex or anal wing do not qualify as sacral sparing. Neurogenic shock versus spinal shock. Neurogenic shock results in the loss of vasomotor tone and sympathetic innervation to the heart. Injury to the cervical or upper thoracic spinal cord, T6 and above, can cause impairment of the descending sympathetic pathways. The resultant loss of vasomotor tone causes vasodilation of visceral and peripheral blood vessels and pooling of the blood and consequently hypotension. Loss of sympathetic innervation to the heart can cause bradycardia or at least the inability to mount a tachycardic response to hypovolemia. When shock is present, it is still necessary to rule out other sources because hypovolemia, that is hemorrhagic shock, is the most common type of shock in the trauma patients and can be present in addition to neurogenic shock. The physiologic effects of neurogenic shock are not reversed with fluid resuscitation alone, and massive resuscitation can cause influid overload and or pulmonary edema. Judicious use of vasopressors may be required after moderate volume replacement, and atropine may be used to counteract hemodynamically significant bradycardia. Spinal shock refers to the flaccidity, loss of muscle tone, and loss of reflexes that occurs immediately after spinal cord injury. After a period of time, spasticity ensues. American Spine Injury Association Impairment Scale, that is AIS. It consists of A, B, C, D, E. A is complete injury. No sensory or motor function is present in the sacral segment, S4, S5. B, sensory incomplete. Sensory but not motor function is preserved below the neurological level and includes the sacral segment, S4 and S5. And no motor function is preserved more than 3 levels below the motor level on either side of the body. C, motor incomplete. Motor function is preserved at the most caudal sacral segment for voluntary and contraction, anal contraction, or the patient meets the criteria for sensory incomplete status and has some sparing of motor function more than 3 levels below the ipsilateral motor on either side of the body. D, motor incomplete. Motor incomplete status as defined in C, with at least half of key muscle functions below the single neurological level of injury, that is NLI, having a muscle grade greater than or equal to 3. E, normal. If sensation and motor function as tested with the ISN CSCI are graded as normal in all segments and the patient had prior deficits, then the AIS grade is E. Someone without an initial spinal cord injury does not receive an AIS grade. Spinal cord syndromes. Characteristic patterns of neurological injury are encountered in patients with spinal cord injuries, such as central cord syndrome, anterior cord syndrome, and Brown-Sequard syndrome. It is helpful to recognize these patterns as their prognosis differ from complete and incomplete spinal cord injuries. Central cord syndrome. It is characterized by a disproportionately greater loss of motor strength in the upper extremities than in the lower extremities, with varying degree of sensory loss. This syndrome typically occurs after a hyperextension injury in a patient with pre-existing cervical canal stenosis. This is a diagram showing the cross-section of a spinal cord showing areas of involvement in the central cord syndrome. The mechanism is commonly that of a forward fall, resulting in a facial impact. Central cord syndrome can occur with or without cervical spine fracture or dislocation. The prognosis for recovery in central cord syndrome injuries is somewhat better than with other incomplete injuries. These injuries are frequently found in patients, especially the elderly, who have underlying spinal stenosis and suffer a ground level fall. Now, anterior cord syndrome. This results from injury to the motor and sensory pathways in the anterior part of the cord. It is characterized by paraplegia and a bilateral loss of pain and temperature sensation. A cross-section of the spinal cord showing areas of involvement in the anterior cord syndrome. The sensation from the intact dorsal column, that is position, vibration, and deep pressure sense, is preserved. This syndrome has the poorest prognosis of the incomplete injuries and occurs most commonly following cord ischemia. Brown-Sequard syndrome. This results from hemisection of the cord, usually due to a penetrating trauma. In its pure form, the syndrome consists of ipsilateral motor loss, corticospinal tract, and loss of position sense, dorsal column, associated with contralateral loss of pain and temperature sensation, beginning 1 or 2 levels below the level of injury, that is spinothalamic tract involvement. This is a cross-section of a spinal cord showing areas of involvement in the Brown-Sequard syndrome. Even when the syndrome is caused by a direct penetrating injury to the cord, some recovery is usually achieved. Now, morphology of spinal injury. Spinal injuries can be described as fracture dislocations, spinal cord injury without radiographic abnormality, that is SUORA, and penetrating injuries. Each of these categories can be further described as stable or unstable. However, determining the stability of a particular type of injury is not always simple, and indeed, even experts may disagree. During the initial treatment, all patients with radiographic evidence of injury and all those with neurological deficits should be considered to have an unstable spinal injuries until proven otherwise. Spinal motion of these patients should be restricted, and turning and or repositioning requires adequate personnel using log rolling technique until consultation with a specialist, typically a neurosurgeon or orthopedic surgeon, is taken. Cervical spine fractures. Cervical spine injuries can result from one or a combination of the following mechanisms of injury: axial loading, flexion, extension, rotation, lateral bending, and distraction. Atlanto-occipital dislocation. Craniocervical disruption injuries are uncommon and result from severe traumatic flexion and distraction. Most patients with this injury die of brainstem destruction and apnea or have profound neurological impairment, for example, ventilator dependence and quadriplegia or tetraplegia. Patients may survive if they are promptly resuscitated at the injury scene. Atlanto-occipital dislocation is a common cause of death in cases of shaken baby syndrome. Atlas fracture, that is C1 vertebral fracture. Fracture of the atlas represents approximately 5% of the acute cervical spine fractures, and up to 40% of atlas fracture are associated with fracture of the axis, that is C2. The most common C1 fracture is a burst fracture, that is Jefferson fracture. The typical mechanism of injury is axial loading, which occurs when a large load falls vertically on the head or a patient lands on the top of his head or her head in a relatively neutral position. Jefferson fracture involves disruption of the anterior and posterior ring of the C1 with lateral displacement of the lateral masses. The fracture is best seen on an open mouth view of the C1 to C2 region and axial computed tomography scans. These fractures usually are not associated with spinal cord injuries. However, they are unstable and should be initially treated with a properly sized rigid cervical collar. Unilateral ring or lateral mass fractures are not uncommon and tend to be stable injuries. C2, that is axis fractures. The axis is the largest cervical vertebra and the most unusual in shape. Thus, it is susceptible to various fractures depending on the force and direction of the impact. Acute fracture of C2 represents approximately 18% of all cervical spine injuries. Axis fracture of note to trauma care providers include odontoid fracture and posterior element fractures. Odontoid fracture. Approximately 60% of C2 fractures involve the odontoid process, a peg-shaped bony protuberance that projects upward and is normally positioned in contact with the anterior arch of C1. The odontoid process is held in place primarily by the transverse ligament. Types of odontoid fracture. There are three types. Type 1 odontoid fracture typically involves the tip of the odontoid and are relatively uncommon. Type 2 odontoid fracture occurs through the base of the dens and are most common odontoid fracture. In children younger than 6 years of age, the epiphysis may be prominent and resembles a fracture at this level. Type 3 odontoid fractures occurs at the base of the dens and extend obliquely into the body of the axis. This is a pre-op image of type 3 odontoid fracture. In the MRI showing the compression of the cord, and the CT scan is showing the fracture line passing to the base of the body, and the vertebral angiogram with a 3D reconstruction showing a naked facet sign. This is the surgical management of type 3 odontoid fracture: patient positioning, lateral view, PA view, and intraoperative X-ray showing lateral mass and C1 lateral mass and C2 pars screw in situ. Fracture and dislocation C3 to C7, that is subaxial spine injuries. The area of greatest flexion and extension of the cervical spine occurs at C5 and C6 and is thus most vulnerable to injury. In adults, the most common level of cervical vertebral fracture is C5 and the most common level of subluxation is C5 on C6. Other injuries includes subluxation of the articular processes, including unilateral or bilateral locked facets, and fractures of the lamina, spinous process, pedicles, or lateral masses. Rarely ligamentous disruption occurs without fractures or facet dislocations. The incidence of neurological injury increases significantly with facet dislocations and is much more severe with bilateral locked facets. Now we are going to discuss few cases. A 45-year-old gentleman, road traffic accident, presented 12 hours following trauma. We applied cervical traction. Intraoperative reduction was achieved after application of the cervical traction. The preoperative image of C4-C5 PIVD is shown in MRI and C6-C7 subluxation. It's causing cord compression. And there is jumping of the facet of C6 over C7. Now intraoperative X-ray showing adequate reduction. In the intraop image shows C4, C5 and C6, C7 plating with spacer placement. This is the post-op X-ray showing implants in situ. Now second case, 52-year-old gentleman fall from height around 20 feet while working in a building, presented 2 days later after getting referred from private hospital, operated on the 4th day of trauma. This is the pre-op image showing C5, C6 subluxation, MRI shows significant cord compression, and CT showing jumping of the subluxation with C5, C6 jumped facet. The post-operative X-ray showing C2 to C6 lateral mass stabilization with implants in situ. The 50-year-old gentleman fall from terrace around 20 feet height, operated on 3rd day of trauma. The pre-op image, MRI shows significant cord compression at C4, C5 subluxation in the CT scan and locked facets. The intraop image showing C4, C5 facet joint on the right side. Intraoperative image showing C3 to C5 lateral mass stabilization with implants in situ. Now patient is supine for anterior approach, that is the second approach following posterior approach. The anterior plating done and the post-op X-ray shows implants in situ, that is 360-degree fusion has been achieved for adequate stabilization. Thoracic spine fractures. The thoracic spine fractures may be classified into 4 broad categories: anterior wedge compression injuries, burst injuries, chance fractures, and fracture dislocations. Axial loading with flexion produces an anterior wedge compression injury. The amount of wedging usually is quite minor, and the anterior portion of the vertebral body rarely is more than 25% shorter than the posterior body. Due to the rigidity of the rib cage, most of these fractures are stable. Burst injury is caused by vertical axial compression. Chance fractures are transverse fractures through the vertebral body. They are caused by flexion about an axis anterior to the vertebral column and are most frequently seen following motor vehicle crashes in which the patient was restrained by only an improperly placed lap belt. Chance fracture can be associated with retroperitoneal and abdominal visceral injuries. Due to orientation of the facet, fracture dislocations are relatively uncommon in the thoracic and lumbar spine. These injuries nearly always result from extreme flexion or severe blunt injuries to the spine, which causes disruption of the posterior element, that is pedicle, facets, lamina of the vertebra. The thoracic spinal canal is narrow in relation to the spinal cord. So fracture subluxation in the thoracic spine commonly result in complete neurological deficits. Simple compression fractures are usually stable and often treated with a rigid brace. Burst fractures, chance fractures, fracture dislocations are extremely unstable and nearly always require internal fixation. Thoracolumbar fracture, that is T11 through L1, fracture at the level of the thoracolumbar junction are due to the immobility of the thoracic spine compared with the mobile lumbar spine. Because these fractures most often result from a combination of acute hyperflexion and rotation, they are usually unstable. People who fall from a height and restrained drivers who sustain severe flexion with high kinetic energy transfer are at a particular risk for this type of injury. This is the preoperative image of L1 burst fracture. MRI showing significant compression of the lower end of the cord and compression of L1 vertebra. This is the intraoperative image showing pedicle screw insertion from T12 to L4 vertebral and posterior decompression in the form of laminectomy has been done. The spinal cord terminates at the conus medullaris at approximately the level of the L1, and injury to this part of the cord commonly results in bladder and bowel dysfunction as well as decreased sensation and strength in the lower extremities. Patients with thoracolumbar fracture are particularly vulnerable to rotational movements, so be extremely careful when log rolling them. Lumbar fractures. The radiographic signs associated with a lumbar fracture are similar to those of the thoracic and thoracolumbar fractures. In these fractures, only the cauda equina is involved. So the probability of a complete neurological deficit is much lower with these injuries. National Emergency X-ray Utilization Study, that is Nexus criteria, meets all low risk criteria: no posterior midline cervical spine tenderness and no evidence of intoxication and a normal level of alertness, no focal neurological deficit and no painful distraction injuries. If yes, then no radiography is required. If no, radiography is required. Nexus mnemonic: N stands for neurodeficit, E stands for ethyl alcohol intoxication, X stands for extreme distraction injuries, U stands for unstable level of consciousness, S stands for spinal tenderness in the midline. Now conclusion: management of neurotrauma is a team-based approach. Discharge of patient from hospital does not mean cure from disease, but rehabilitation of neurotrauma patient is a real challenge for healthcare workers. Adequate nutrition, physiotherapy, proper positioning with bladder and bowel care gives a better overall outcome. These are my references: GCS remastered recent update to the Glasgow Coma Scale GCSP, Student Course Manual ATLS 10th edition, Brain Trauma Foundation 4th edition 2016. Thank you for your kind attention.